I'm Randy Olinger. I'm with Optum, and I'm going to have a little bit different slant before we do our panel. There's a couple other presentations after me. But I'm going to talk a little bit about our path on big data. I'm titling this Big Data is Now a Noun because in the past year, people have started acting or using it as a proper noun and treating it as if it's an entity as opposed to a description of something. Does this work? Okay, good. So for those that don't know me or know Optum, we are the largest, by far, healthcare company in the US and probably the world. Healthcare services company, I should say. We employ a lot of people that reach out to end users or consumers, a lot of nurses, a lot of call center agents, and we have consulting services, and we have point-of-care clinics now, and we've opened up our own hospitals. So there's just it's just been a really growing business over the last 2 to 3 years. But then again, it's been around for 15 or 20. I know this sounds like marketing speak, and a lot of this presentation may be that way, exploring the convergence of data and care models, but those are some of the things we do. One of the things that I've found interesting is the wellness programs and what they really mean. And I'm going to be showing a little bit of how our use of our use of data is able to connect up people that can help someone with the consumer and help them either manage their care or provide care to them in a better way. And we also live in a world of privacy and regulatory statutes that are a myriad. It's very difficult sometimes to navigate that. So one of our challenges that has become a big deal in the last year is the multiple identities of a constituent. If you think about it, most of you here have probably worked for more than one company in your career. And as you moved from companies, you probably moved from healthcare plans. And those healthcare plans, it's very likely they contract with us for something, to do something for them, like a wellness program or a HSA or something, a healthcare savings account. And so we might have you on our databases multiple times. And so getting that down to a single person is really important for us to be able to treat you as a consumer and not as 3 different consumers. Like I said earlier, we have a lot of data regulations, particularly around privacy and retention. We also are a bank for the healthcare savings accounts, so we have all the banking regulations that go along with that. We've done 500 acquisitions in the last 10 years. That, the math isn't exact, but it's pretty close to 1 acquisition a week. That's a lot to ingest. And it's one thing to say we did 3 acquisitions in 3 weeks. It's another thing to say you did 500 in 10 years. That's an awful lot of disruption to the businesses we acquire and to our internal businesses. And we have just generally realized that if we can integrate the data better, there's a lot of untapped value to provide better outcomes for people in the healthcare industry and also to take cost out of the industry and hopefully put it back in the consumer's pocket or in the taxpayer's pocket, depending on who's paying the bill. We use slides like this to illustrate sometimes what we're all about. So I thought I'd show it. It's a little bit fluffy. I apologize for that. But it kind of shows the way a patient or a consumer might interact with our company. And the thing to think about is this shows happy people smiling all the time. When you're really sick or you just found out you have lung cancer or something like that and you're calling us and talking to us, you're probably not smiling. You might be devastated. So it's not always a really easy journey through this place we're taking people to. But we're working to try and make it as good as we can. And the idea is that I'm not going to talk through every one of these points, partly because the writing on here is really small. But the idea is that a person might call in with one type of an issue. We might discover they have another type of issue. And if we can connect those dots, we can help that person in a new way. Whereas we just treated them as 2 different individuals and waited for the person, waited for some other way to discover, in this case, this guy named Greg, who has depression along with his diabetes. If we didn't have a way to connect that, it might take years or we might never find out he had depression. So the use of this data is as an advocate for the patient or the consumer. And it's a lot of data. We have roughly probably half the people in the United States, have somehow interacted with us over the years. So that's north of 100 million people that we're trying to I don't want to say keep track of because that kind of freaks people out, but north of 100 million people that we have information on that may end up contacting us in some time in their life. Oh, I'll get to that later. This is another way that we kind of describe some of our data and how we connect the dots together. So we're in the process this year of building another type of warehouse. Now, we've all done data warehouses, that's what we call it in the enterprise world, which are just, usually big relational databases with lots of tables, and we shove a bunch of data in, and then we find ways to take out information and use reporting tools and hire data scientists, and we've been doing that forever. But we're trying to take a little bit different view of a warehouse now as a way to enable these different segments of our company to work together. Normally when someone had a data warehouse, it was like, give me all your data, and then I will hire people to go do analytics and figure out, and then someone else has an idea, well, they go set up their own data warehouse, and they set up their own data warehouse, and we have multiple copies of all this stuff. We're trying to single instance it, not just to save money, but also to make the data more consistent and improve the data quality. So we're calling it a 360-degree view of the customer, which you hear a lot in the enterprise these days. And we take together, in this case, we're showing an individual profile, a health profile, benefits and financial information, and an interaction profile. Interaction would be when they call us, contact us, use our website, respond to a text message, that kind of a thing. And we have programs we call synchronization, which is trying to bring together all their doctors and nurses and drug use and pharmacists and things like that. A digital experience, which is really a fancy way to say our better websites and use of technology. And advocacy is kind of a new thing in the healthcare industry where you hire a company to advocate on your behalf to basically argue with either your doctor or your health insurance company or Medicare or whoever you happen to be arguing with at the time to get your healthcare figured out. So we've got a small business we're starting up in the world of what we call advocacy. And offer management and preference center, that's more about how do we extend new things, new ideas to people using standard tools that have been in the e-commerce business for a long time. This slide kind of depicts some of the different activities that we have that relate to individuals. And I guess the only point is not to read it all, but to know that there's a lot, and trying to tie together information from that many systems can be quite a challenge. And again, they tie into those 4 segments that I talked about earlier. I think if there's anything interesting I can point out here. Oh, one of the things, great buzzword you hear in the industry a lot now is Internet of Things. One of the areas we're exploiting that, which is bringing in a ton more data, is in the use of in-home diagnostic devices. So you might have a health or a blood pressure monitor dropped off by a nurse that we sent to your house, and then if you use that 3 times a day and it reports in through your Wi-Fi connection or through a 4G cell connection what your blood pressure readings are, we can then triangulate that. If we see something disruptive, we have systems that are scrubbing that and looking for problems, and if there's either a rise in blood pressure or something, or lowering, if that's what we're monitoring for, or maybe it's a blood glucose monitor or something like that, we're able to now use that data to figure out when it's right to reach out to a person through an intervention call, like from a nurse, and that's kind of a big deal. It's one thing to grab a bunch of data, it's another thing to do something with it, as we all know. Okay, so what is some of this thing I'm talking about? So we have, we're trying to migrate some of the hardcore analytics we've done to parallel open source systems, Hadoop and Spark and R and Kibana, some things you've probably heard of, and having decent success doing that. We're doing a lot with visualization from either open source products or proprietary or enterprise type products, but the big deal there is trying to bring that analytic capability down to people who aren't necessarily data scientists. So again, if we can detect the data quality problem, one of the big things in the healthcare industry is getting people paid on time. So it might be 6 months sometimes between when you go to a doctor and that doctor actually gets paid by Medicare or your health insurance company. And if they can do revenue lifecycle management, that's a fancy word for saying get paid sooner, it's a big deal. There's lots of, and of course, whenever money is sitting in a system, it leads to all kinds of other inefficiencies. So we spend a lot of time trying to find when people are doing electronic submissions if they have their P's and Q's mixed up and try to detect that stuff early. The other thing that's real popular is representing the cost of care geographically. I wish I had a picture of this, but it's kind of interesting to see some of these things. There's a really large discrepancy in how much the same exact procedure costs in one part of the country versus the other, or of course different parts of the world. But then you get into national, national politics or national healthcare system differences. But just in America, there can be vast differences in the cost of things, and by pointing that out, we can help insurance companies or users pick the best thing for themselves, for their pocketbook. I better move along. I'm going a little long here. The other thing we're looking at is a longitudinal and comprehensive consumer data record. Now, longitudinal, I don't know, maybe I'm the only one, but I think that's a fancy word that our marketing people say to our business people so that they can sound smart. But what it really means is, over time, taking all the data points we have on someone and putting them together in a string so they can see the entire record of the patient, as opposed to seeing little bits of it at a time through different systems. So we're using a NoSQL database and a canonical data model and some tools to do data translation to bring it in there in an automated fashion. And the hardest thing in this was to get all the systems in the company to agree to start sending their data to this one place, because everybody wants to put their arms around their data and hold it close and not let anyone else see it. But in order to do that, we had to also build a data level security layer in also, because with regulatory issues such as HIPAA, we're not allowed to just open up the door and let anyone see any data they want. Anyway, we're hoping to take down over 20 data warehouses, resulting in a lot of reduction in cost. Okay, this I don't know. This just kind of shows some of the different. We call it kind of a hierarchy of our data. Where we get the most value out of it is, of course, at the top, and as we go down, we have more and more, larger amounts of data and less information. Some of the words you see up there, I don't know if people are familiar with the word identification stratification. It's the data scientists sift through large amounts of data and look for people to target. So if you had, 20 million health records or health assessments and you went through and want to find out who the smokers are, that would be an identification stratification. That's a very simple one. It's never that simple. Well, actually, for smoking, it can be that simple, but for diabetes prediction, it's never that simple. And then as we move up the stack, we're trying to get more and more useful, actionable information into our clinical people. So like I said, our Optum Big Data Platform, our reference architecture, looks a lot like things we've seen in the past. The big difference for this is we have this thing we call data lake, and people have all heard of data lakes, which is a big Hadoop farm, and we just kind of shove all the data into and leave it in its unstructured form or its native form. And that can be used for analytics or it can be used to feed other systems. But the canonical data processing moves it into a NoSQL database, which creates all those orange cylinders that say 360s on them, and consumer ID and provider ID. So that is what I would call enriched data that is also scrubbed and denormalized. But the fact that it is non-relational and schemaless allows us to better integrate multiple different data types without having to tear down the house every time someone comes up with a new data type. I think that's let's see. No, that was an extra slide. This particular picture was just meant to show how how things are different using this technique versus the way we used to do it. In our old way, we would have n number of systems trying to talk to m number of other systems, and it'd be n factorial over m factorial number of connections or some crazy relationship like that. And it really resembles more like an enterprise service bus where people can send data into the system and it figures out where it needs to go and it gets it to the other people. So it can simplify a lot of the transactional nature of sharing data between systems. And this is live this year. We're rolling this out in 2016. That's all I got. So we'll move on to the next presenter. So Harriet, would you like to go next?